Let me ask you about this FAST, F-A-S-T, FAST system of symptoms. What is that?
Yeah, that's an acronym that people remember. FAST, what happens? FAST, what's FAST? Face, arm, speech test. What's the face look like? Is there asymmetry? Because a lot of people present with acute weakness of the face. Arm, is there weakness of the arm? Can you ask them, if you ask them, raise both your arms up, you know, if they do this, you know, or one arm is kind of droopy, that's weakness.
Sure.
Right? Speech, is their speech slurred? Can they enunciate properly? Is the language coming out appropriately, or is it kind of gobbledygook, you know, gibberish, or are the words difficult for them to form or enunciate? So slurring. So the face, arm, speech test, that's kind of a fast thing that you can kind of test somebody with if you think somebody's having a stroke.
And that's something that really maybe somebody with a person of the right age, if you will, should really know about, just like they should know about what to do if a heart attack begins.
That's right. That's right. Yep.
To do that. Now, you're working on that, of course, at the hospital. How is stroke diagnosed? If somebody comes in between the heart attack, stroke, or something else that may occur, what's the diagnosis right away? Is it made in the ambulance getting you to the hospital, or once that person arrives there and the team gets to work?
It can be tricky, and that's where the finesse, that's the art, you know, of medicine, where that comes in. Some strokes are very clear. If somebody's walking along and out of the blue, you know, half their body goes, you know, weak and they can't walk. You know, in that case, the EMTs usually make a diagnosis and phone that in. Most of the time, it's more subtle than that. And the diagnosis is really only initially made on how the person appears. What is their functional status? What's their neurological examination show? Are they weak? Are they numb? Do they have a deficit in their vision? Can they see properly? Are they speaking properly? So they have to have kind of a, you know, a full kind of neurological evaluation to get at the clinical diagnosis, what we call the clinical diagnosis. And then, you know, the other layer of diagnosis is, well, what can we show is happening in their brain? You know, so we do a CAT scan. You can do an MRI, which is a magnetic resonance image picture. You can do pictures of the blood vessels. So that's the objective diagnosis that will give you an idea of kind of how big of a stroke or what part of the brain it's affecting. But by and large, it's really the clinical status. It's what happened. And we can share that information with primary care doctors and with people in the field so that really most people should be able to recognize, you know, at least the common FAST, face, arm, speech, patterns of strokes.
Now, Greenwich Hospital is a designated stroke center. Tell us a little bit about that, what that means, and how you work at it. You're the director of that, as we said at the beginning of the program.
We're quite proud about that. Initially was a lot of work for us to put together. What it means is the Joint Commission, which is the National Accrediting Board in the United States, put together what's called a disease-specific certification. So they have a primary stroke center, and they have a diabetes and a kidney failure, and there's about 6 or 7 disease-specific certifications that hospitals can apply for. So the primary stroke certification requires that you track, submit, and are able to provide the high levels of standard care which are required kind of for stroke care. So, you know, there's an application process in terms of showing how you manage stroke, what you can give for stroke, what your outcomes of stroke are. And a large portion of that is whether you can give TPA, which is the clot-busting medication, which we haven't talked about yet, which can only be given within 3 hours. So in order to be able to give that, you have to be able to triage the patient fast. You have to be able to get the scans fast, which requires involvement of the emergency room, the radiology, the radiologists, the radiology technicians, the laboratory. So it's a very concerted effort on multiple levels. Really nothing like it in our hospital in terms of the number of people that have to be involved and the depth of the involvement there.
Let's talk about the TPA. What is that, and what's it entail?
Yeah, TPA came out in the mid-90s, and it's a thrombolytic. It allows, it dissolves clots. And for stroke, we can only give it within the first 3 hours. Now, the numbers may be extended in the next couple of years, such that we may be able to give it within 4 or 4.5 hours. You know, the prior data showed that if you gave it too late, there's a higher risk of bleeding because this medication dissolves clots, but it also makes the blood very thin.
Sure.
So there's a risk of bleeding for it. So it's, you know, what I tell patients, it's a bad drug for a bad disease. So somebody comes in with an acute stroke, and you think it's going to get much worse before it gets better, and you think there's a chance that you can salvage a lot of brain, then they're a candidate for that clot-busting medication if they come in within 3 hours, which is why it's so important for people to recognize the symptoms, get to the hospital as fast as they can so that we can give the medication to them.
There's something I've heard of, a silent stroke. Is this like a silent heart attack? Somebody has had a heart attack, has been told, oh, gee whiz, you know, you had one, but everything's perfectly fine. Talk about that a little bit.
Yeah, silent strokes, or let me talk about a TIA.
Okay.
Because I think that feeds in there. A TIA, a transient ischemic attack, that's where you have the symptoms of a stroke: weakness, numbness, speech changes, visual changes, that only last an hour or two. You come into the hospital, we do all the pictures, we don't see anything on the scans. There's no evidence of any kind of damage on the scans. So you had the symptoms, but you didn't have any objective damage. That's a short, you know, some people refer to that as a mini stroke. The problem with those is a lot of people will discount those. You know, they'll stay at home. You know, their symptoms resolve, they don't come in. They don't let anybody know it happened. The problem with TIAs is, you know, up to 15% of those will have a stroke within the next 3 months. So it's a harbinger of a stroke. Now, sometimes you don't have any symptoms and you have a little atherosclerosis, or hardening of the arteries in your brain. There's something I like to tell my patients: you have a little rust. It's a little brain rust, right? Which is atherosclerosis, cholesterol, high blood pressure, diabetes predisposes to that. You can have these tiny micro strokes that don't have any symptoms. So you go in, say you go in for a, you know, you have a headache, and you go in and they take a picture of your brain, and your doctor says, well, you had a little stroke there, you know, and you say, well, I've never had any symptoms of that. And so that's, you know, that's a way to kind of check, you know, let's look at your blood pressure, let's look at your cholesterol, let's look at your medications, let's look at your family history, let's see what your risk factors are. Because if we can minimize the risk factors, then we can bring your risk down to near kind of what you would be without those risk factors.
Sure. Interesting with that, because a lot of people will again wonder or maybe take things on their own. I think that's the biggest danger in everything of this. Well, I'll wait. I'm not going to tell anybody. But that's the danger's there.